Hello everyone, a warm welcome to our today's webinar, which is going to be a masterclass on thoracic ultrasound. We have the best faculty today to teach us, to enlighten us on this fabulous topic, which is so very important in our day-to-day practice. Can we please have the faculty being shown to us, please?
Hello, good evening.
Good evening.
Hello, good evening.
Yeah, a warm welcome to Dr. Priya, Dr. Uma, and Dr. Nishant. Can we please remove the form today's fire, please, tech team? Okay, so we are really looking forward to this masterclass on thoracic ultrasound, for which we have the most distinguished and accomplished faculty of our country who's going to teach all of us all the important things that we need to know about ultrasound, whether it's of the lungs or of the pleura. And I would like to really thank our partners, GSK, for helping us, giving us the platform, and for the initiative. I would like to greatly thank Indian Chess Society and our president, Dr. Sandeep Salvi and Dr. Rajadhar, for their excellent initiative, and our entire governing body for making sure that we have wonderful webinars week after week, every Wednesday, with the best faculty of our country. We have decided that because it's a masterclass, we're going to have a small poll. So I request all the delegates to please go in the chat box. There are a few questions. Please answer them right now before the webinar starts. And then at the end of the webinar, we'll also have a feedback to know how much you all have learned from us. So now I'd like to start the first talk, which is from Dr. Nishant Sinha. So can we have please the slide of Dr. Nishant Sinha? Wonderful. So Dr. Nishant Sinha needs absolutely no introduction. He is a senior consultant pulmonologist at the Continental Hospital, Hyderabad. He's done his respiratory medicine training from CMC Vellore. And after that, he's done advanced respiratory medicine training at the Essex Cardiothoracic Center in the UK. And he's also worked as visiting trainee in ILD unit and National Pulmonary Hypertension unit at the Royal Brompton Hospitals, London. He is the faculty for regional EBUS and thoracic ultrasound workshops, and he has done focused training on so many things. So he is one of the most respected faculty on lung ultrasound. And over to you, Dr. Nishant. We look forward to listening to you.
Yeah, thank you, Dr. Amita, for this introduction. I would like to thank the GSK team and even Dr. Amita for taking this forward, and such a wonderful meeting we are having now. The talk which I've been given to start with is basically, it starts with the basic ultrasound knobology. Is my screen seen?
Yes.
Yeah, so basically this talk is going to be very basic. The disclaimer is it's going to be very basic. Yeah, so basically this screen has got two parts of it. In the left side there's one machine, right side there's another machine. So left side is the machine which we use in our wards in the ER, and right side is the machine which is a touch screen which we use in our ICU. So if you see this carefully, there are many buttons here which I'm just going to speak a bit of it here now. There's something called gain, depth, there's a central cursor button, there's a set and pause, then there's a on off switch button, and there's a probe setting, and this is called time gain compensation. So it looks a little confusing here, but I'm going to make it very clear in the next 10 minutes. So this is my disclaimer slide, and also I'll add it's going to be a very basic talk. So all you need to know about knobology is this: what are the types of probe we use with some basic physics, gain, depth, focus, Doppler, the typical modes we use, freeze, calipers, and finally image and video capture. Generally we are very busy and we miss the last part. We don't record these video or images, but we should do it to teach in our forums. So if the machine is your own department, you will do it very well. But if you are borrowing it from ER, ICU, or radiology, it's going to be case based and you may not have time to record all your images or videos. So coming to the probes now, there are basically three types of probes. One is a linear probe, other is curvilinear probe, and the last is phased array probe. If you see the phased array probe, it has got a narrow footprint, but it can go deep, and it has got low frequency. So it can see deeper structures better. If you see the linear probe, it has got high frequency and it can only see superficial structures. And if you see curvilinear probe, again, it has got wide footprint. That means it can see a little wider, but at the same time, it can see deeper because it has low frequency. So if you see in the right side of this slide, there's a graph which is very, very, very basic and very important. So in the y-axis we have resolution and penetration, which is increasing in one side and decreasing the other side. In the x-axis we have frequency. So if you see phased array probe, it has got frequency from 1 to 4 megahertz, and that's the penetration of it, and that's the resolution. So it looks to be ideal probe, but in my work, I think for me curvilinear works best, and after that I use linear. But if you look at the theory, phased array probe is really good actually, because it can penetrate deep. It has got good resolution. If you see curvilinear probe, it has good resolution, but it cannot penetrate that deep. And if you see high frequency probe, it has got best resolution, but it can only see superficial structures because it has got least penetration. So coming to gain, what is gain? So basically it is nothing but gain is when the ultrasound beam comes out from the machine and it goes deep in the body. I was talking about the gain, sorry for interruption. So basically when the ultrasound beam starts from the machine, it goes deep in the body, it gets weakened to the extent that when it comes from deeper structures, it looks weak, and when it comes from the superficial structure, it looks strong. So gain is basically a mechanism to dampen this problem, and the machine gives it a uniform image to us. So this is a correlation of gain. If you see in the x-axis, there's something called distance from transducer. In the y-axis, there's amplitude ratio. So as the distance increases from the transducer, the machine also increases the amplitude of the signal which is coming back to us, and that is called increased gain from deeper structures. So if you take too much of gain, it will look white. If you take too less gain, it will be black. Sometimes you may be busy and you just want to do the machine ultrasound on a patient. Look carefully at the gain first, because otherwise everything will look black. So there's something called time gain compensation. It is nothing but it is a differential gain of each part of the image. So if you take as 8 centimeter depth of your ultrasound beam, so you can decrease or increase the gain at each level of your ultrasound point in the patient's body. So this is how it is. If it is at 1 centimeter, it will be a little less gain, but if it is at 3 centimeter, the gain will be more. So this is -1 gain at 1, but at 3 or 4 it is +1, +2, like that. So as so on and so forth, this machine can adjust. I'll show in the video about that. So this is a typical example of that. If you see in the left side, there's an image called A, in the right side image called B. So in the A, this is everything is in the center. They have not adjusted the gain. So look, it looks black here. Lower down you can't see. But if you take a good gain in the lower part of image, so this is like 1 centimeter, 2 centimeter, 3, 4, 5, 6, 7, 8. So they increase the gain in the lower part, and they can see the B lines very clearly.
Dr.
The same
Nishant,
thing
we can only see the gain slide right now. The slide is not moving on screen.
I'm really sorry, because it's moving for me. I can see it very clearly.
Definitely team GSK has unfortunately.
They have to do it something, because I can see it moving. It's full screen.
No,
I think if that is the case, then you can start the next talk. We'll come back to it.
Yes, let's do that.
Yeah, do that. I'll talk to them. Yeah.
Dr. Uma, we will come back. We are sorry, Dr. Nishant, about this.
Sorry, it's all right. Okay.
Yeah.
Okay. So now coming to Dr. Uma. Dr. Uma needs no introduction at all. She is a fantastic pulmonologist, a brilliant researcher, and an ultimate authority in lung ultrasound. And most importantly, she's an extremely dear friend of mine. And I know her for the last 15 years, and I feel blessed to know her. She truly requires no introduction. She's a professor pulmonary medicine at the very famous St. John's Medical College, Bangalore. 46 publications, peer review in indexed medical journals like Our Lung India, Heart India, Annals of Internal Medicine, NEJM, and Respiratory Care. She's conducted so many lung and critical care ultrasound workshops. She's a coordinator for development of training module of TB Karnataka Health Promotion Trust. She's in charge of the respiratory intensive care at the St. John's National Academy of Health, Bangalore. And she is the site primary coordinator for the International Sleep Research Training Fellowship Program. Over to you, Dr. Uma. We look forward to listening to you.
Thank you, Amita, for that kind introduction. I am really honored to give this talk right now. I think it's a very, very interesting field now, with the ultrasound coming majorly up. So let me straight away go into the topic as such. So we'll go into normal lung ultrasound. So before going into the topic as such, few basics we need to know. So we should know that in the thorax, air and water are intimately mingled. So before, if you see the 15th edition of Harrison, it says that ultrasound is the lung is the enemy of ultrasound. Okay, so we cannot use ultrasound to image the lung. But now we know that without ultrasound, the thoracic imaging is not complete. So it has come to that level. So it all depends on how we are interpreting as such, like how in, say, in the abdomen you see liver as liver and spleen or kidney as such. But in the lung ultrasound, it is all by interpretation of artifacts. So that is how we go. So all the signs are arising from the pleural line. So that is an important point to remember. And lung signs are mainly based on analysis of artifacts. As I said, it depends on how the lung absorbs the ultrasound and reflects it back. That creates artifact, and that's how we are interpreting the artifacts to come to the conclusion as what is the underlying pathology. And most important, lung is a very vital organ. So all the time it is moving. So most of the signs are dynamic. It is not like X-ray. You just put up the image and then you are interpreting. So it's very, very vital, and it keeps on moving. So that's how we interpret the ultrasound. And for us, very fortunately, most of the signs will be from the start of the pleural line, because all the acute disorders of the thorax will come into contact with the surface. So that explains the potential of lung ultrasound. Anything which comes into contact with the pleura will be able to analyze the artifact and interpret. Next slide, please. Next slide, please. So lung acts as a densitometer. So here you can see on the left that air, whatever happens, ultrasound will just penetrate, superficially. Air tends to reflect it back. So it has a greater impedance. It will not allow the ultrasound to pass through it. Whereas compared to that, on the right side, if you see water, it will allow the ultrasound to pass through it. So for example, if you note in ultrasound abdomen, most of it, the patients are asked to come in full bladder, because that full bladder will act as a very, very good mirror or a window, so through which the ultrasound is passed, and then you can look at all the other structures. So that's how, if you have more water, you can make the ultrasound pass through it and interpret the images clearly. Next slide. Next slide, please. Yeah. So here we have the extremes of the air and water content in the body. Okay, so if we have completely air, 100% air, you can see that, say for example in pneumothorax, okay, the ultrasound is not able to penetrate into the lungs. So you will have absolutely like a, the pleural image will be there and it will not move. Compared to that, if you have increased water content, for example in a pulmonary edema, you will have lot of other types of artifacts, what we call as B lines. I will come to what is A lines and B lines in my subsequent slides, but this slide tells us the difference between the air and water content in the lung. So that will make the difference and help us to identify the underlying artifacts. Next slide, please. So what are the main landmarks when you're doing the ultrasound? Next slide. So first is the pleural line, or what we call as a bat wing sign. So here you can see this is the the high resolution image, where you have the high resolution, the linear probe which is being applied on the chest wall. The red line depicts the two on the top, that shows us the rib. So the bone will not allow any ultrasound to pass beyond it. So beyond this rib, that is the lateral ones which you see, everything is black. So the ribs are stopping the ultrasound, and beyond that you just see a shadow, black shadow. And in the right, in the middle, you white structure, the topmost white structure, that is the pleural line. Okay, so these two rib structures and the pleural line together give an image like as though the bat is flying towards you. So this is called as the bat sign or the bat wing sign. Below the white pleural line, you can see at equidistant, just from the pleural line to one more horizontal line you can see, and below that another horizontal line. These are nothing but reflections of the pleural line from above. So the ultrasound hits the pleura, it gets reflected to the machine back, and again it comes and hits the pleura again. So this causes a reverberation artifact. So this gives rise to what is called as the A line. So if you note, from the skin to the pleura, that distance. So equidistant to that, you have the first A line and the second line, so on and so forth. So A lines are nothing but horizontal reverberation artifacts which reflects the pleural line. Next slide, please. So here you can see this is the B mode. Okay, so here you can see the main landmark that we have to see is the pleural line. So here you can see the linear probe. Okay, and below that is all your subcutaneous tissue and muscular plane, and there are, you can see a bright white line. Okay, so that is the pleural line. So you can see how the line is shimmering and moving, small movements you can make out. So this is called as lung sliding, where it reflects that the ultrasound is hitting the pleura. Okay, and you have the two pleural surfaces. You have the visceral pleura and the parietal pleura. So in between, it gets reflected between these two, and this gives rise to the bright white structure. So whenever there is any difference between the ultrasound passing through a different echo texture of the tissues, that reflects the ultrasound, and that gives rise to a white like or a bright structure. For example, pleura is one example. For example, another example will be the diaphragm. So here in the diaphragm, you will see that you have the lung which is full of air, and then you have a very tissue like or a solid like structure which is the liver. So in between, the diaphragm is there, and that's because of the difference between the air content and the fluid content between these two structures, the diaphragm will look as a bright white structure. So on the left hand side, you see the pleural line, which is the bright white structure which is shimmering, which is sliding. So this is called as lung sliding. So this is the linear probe. On the left of your picture, you can see that this is the linear probe. You can see how the footprint is there. It is like a sector probe. You can see like a sector. In the top most white structure, this is the pleural line. In between, you can see the black shadows because of the rib. The ribs do not allow the ultrasound to pass through it. So this gives rise to this type of an image. Next slide, please. Okay. So what do we see here? Okay, so here you can see the linear probe. You can see the skin and the subcutaneous plane. Is the pleura moving? Okay, not very much. You can see that it is moving en masse. Okay, both the subcutaneous tissue and the muscle and the pleura are moving together en masse. They are moving both towards towards the either side of the screen together. It is not one sliding over the other. So this represents lack of lung sliding. It is not one sliding over the other. It is like together, it is moving like in this manner. Next slide, please. So this is loss of lung slide. The next landmark which we need to notice is the diaphragm. As I explained before, here we have to keep the ultrasound probe in a longitudinal fashion between the ribs, okay, where you expect the diaphragm to be. So we visualize the lung above and the diaphragm and the liver below. Next slide, please. We can show the bright white structure. Okay, so on the right of your screen, okay, when you're facing it on to the left of your screen, you can see that is the liver. You can see one or two hepatic nodules, veins, okay, the black structures like that, and you can see the diaphragm. Okay, so now you can see that the liver is bounded by the
great,
like this. Okay, you can see one or two hepatic venules, and on to the other side, the diaphragm is a curvilinear whitish structure. Okay, on top you have the skin and the subcutaneous plane, and to the other side you have the lung, which is coming in, pushing the liver down. As the patient is inspiring, you can see the liver is moving down. As the patient is taking a breath out, the liver is coming back. So this is called as the curtain side. Okay, so the main landmark is the diaphragm, and we also make note of whether the lung is coming, it is moving, and this gives rise to the curtain side. Next slide, please. So here is another representation of the A lines. You can see the arrows are pointing towards the A line. The topmost arrow is the pleural line, and below that are just nothing but the mirror images of the A line. So these are reverberation artifacts. This is the reverberation artifact, horizontal artifact called as the A line. Next slide, please. Again, you have to play this video. No, the previous slide. Yeah, this is a video. Yes. So now we can see as the video is playing how the A lines appear and disappear. Okay. So these are where if you see A lines, that means the underlying lung is normal. It is normally aerated, and A lines are moving. That means lung sliding is also present. In a normal lung ultrasound, if the underlying lung is normal, you will see lung sliding and A lines. Next slide, please. So if we switch from B mode to M mode is nothing but motion mode, where you see on top of the image, the top part, you can see a single line, white line. Okay, so that is the M mode, where you have a single beam of ultrasound passing through the tissues, and what is detected is motion of the underlying tissues across this ultrasound beam. So here in a normal ultrasound, you can see this white structure, white line on top. So that is the pleural line, and below that you see grainy picture. So this is called as a seashore sign. So in a normal lung, if you see a pleural line plus a seashore, that is the grainy picture underlying beneath the pleural line, so this represents a normal lung ultrasound. We will see in the pathology, lung pathology, what will happen in other lung pathologies, what happens in M. Next slide, please. So next we go to the next artifact, what is called as the B line. B lines are also called as comet tail artifact. They arise from the pleural, and again B lines are nothing but reverberation artifacts. You can see from the image that when the ultrasound beam is passing through the tissues, okay, the uppermost part is your pleural line. So if the lung has more water content, what happens? It will go and hit the interstitium. Water content in the lung means water is there in the interstitium. For example, in pulmonary edema or in interstitial lung disease, what will happen? The ultrasound goes and hits the interstitium, and there is a reverberation and it reflects back. It will go and reflect into the other part of the interstitium or within the alveoli itself. So that it goes back and forth, to and fro. So that gives rise to multiple small horizontal artifacts, which goes from the pleural line on top right up to the edge of the image. So B lines are nothing but a comet tail artifact which arises from the pleural line above, reaches right up to the edge of the image. Usually they are hyperechoic. Hyperechoic means more bright, more white. So hypoechoic means if it is more black, it is called as hypoechoic. We have to remember that B lines are hyperechoic white lines. They are very well defined, sharp and laser-like. And whenever you see a B line, it will always erase the A line. You cannot have simultaneous A line and B lines together. Whenever you have the appearance of the B line, it will erase the A line. And usually the B lines move across the image. So they move with the lung sliding. Next slide, please. So here is a image of the B line. So as I said, it starts from the pleural line above. You can see the points marked with asterisks. It reaches right up to the edge of the space. So this is a single B line on the left hand side, and on the right you have multiple B lines, 3 B lines. Anytime you can see, say for example, in the lowermost part of the chest, in the lower lobes, sometimes just above the diaphragm, sometimes you can see in a normal person also B lines. So up to 3 B lines are considered normal. But if you see more number of B lines, or sometimes say even in the upper part of the chest, if you see B lines, that is definitely abnormal. There is some underlying pathology in the lung. Next slide, please. So this is the video of the B lines. You can see how the B lines are arising from the pleural line. It is reaching right up to the edge of the image. This space is called as Merlin space. It is reaching right up to the edge. Many times, sometimes if you see these vertical lines which are midway, they are disappearing. they are not called as B lines. B lines have to, the definition of a B line is it has to come from the pleural line and go right up to the edge of the image. Next slide, please. So next we see what will happen if you have underlying, say, a pneumonia or a interstitial disorder, what we call as peripheral parenchymal lesions. So here the pleura has become broken. You don't get a continuous pleura. So this image shows us the imaging of the pleura in a horizontal. Okay, you can image the chest either by a vertical imaging or the horizontal. Here it is horizontal, means you're putting the probe horizontally between the two ribs. So here you can see that the pleura is broken and the arrows are pointing to the peripheral parenchymal lesion. So whenever you have small pneumonitis or say subpleural infarcts, for example, even in a pulmonary thromboembolism, or if you have, this is called as a focal interstitial pattern. Anything can give rise to a focal interstitial pattern. For example, small pneumonias, infarcts. So in those instances, you will see this type of an image. Next slide, please. So we have seen what are the main artifacts. We've seen what is an A line, what is a B line, how to visualize the diaphragm. We have seen the curtain sign. So there is something called as a profile when we are going to interpret a patient, who's come with dyspnea, and how to approach the dyspneic patient with our lung ultrasound. We need to keep in mind these profiles. There's what is called as A profile. When you scan the patient on both sides, that is both the hemithoraces are showing A profile in both the lungs, where you have lung sliding is present, both sides you are seeing very nicely A lines, then this is called as an A profile. In contrast, when both the hemithoraces are showing lung sliding, but lot of B lines are present, so this type of imaging on a patient, it is, so this patient is supposed to have a B profile. In contrast, suppose in a patient who is dyspneic, say on one hemithorax, when you're scanning, you're seeing all A lines, but on the other contralateral lung, when you're scanning, you're seeing the lung sliding is present, but profuse B lines or a lot of B lines. So it is called as AB line. So one side A and the other side B. So it is called as AB profile. Next slide, please. So here you can see a consolidation. Okay, here you can see this is a sector probe. You can see how the image is projecting here. It's a sector probe. You can see the subcutaneous tissue. The pleural line is not well defined. It is very, very broken. So absolutely you're not able to see the pleural line. And what you see is the hyperechoic white jagged line. Okay, so it is almost like, shredded paper, that edge. So this is called as a shred sign. Just above the shredded white line, you can see a lot of white dots moving. Okay, so that is the air bronchogram. So air will appear white on ultrasound. The ultrasound imaging is actually exactly opposite to what we see in X-ray or CT scan. So in the ultrasound image, air will appear as white, fluid will appear as black. So here in this image, you can see the edge which is shredded, and in between you can see few white specks. Those are air bronchograms. So this is a picture of a consolidation. So this is how a consolidation will appear. So in a distinct patient, suppose if you see one side he has all A lines, or suppose on both sides he has this type of a picture like a consolidation, lot of shreds are present, then this is called as a C profile. Next slide, please. So this is again a representation. One side there is A lines, and the other side we are seeing the consolidation. This is a C profile. Next slide, please. Yeah. So that brings us to a conclusion. A lines, we saw what is A line. These are nothing but horizontal reverberation artifacts, represents the reverberation or a mirroring of the pleural line. We saw what is lung sliding. We saw the B lines, which are nothing but lung rockets, and then we saw the different profiles. Then when we see the lung pathologies, then we can see how we can approach a patient with dyspnea. Thank you. Over to you, Amita.
Uma, that was fabulous. I mean, it was really a mesmerizing presentation. I think you made everything so very clear and you taught fabulously. I think this was one of the best lectures I've heard till date. Thank you so very much, dear Uma. Team, I would like to ask you all, can we go with Dr. Nishant's presentation or Dr. Priya's? What do you all feel? Dr. Hardik, can you all tell us whose presentation should we go with now? And can we just stop sharing this presentation? Dr. Nishant, have you resend the slides to them?
Ma'am, we can go with Dr. Priya's presentation first, then we'll go with Dr. Nishant's.
Sure, done.
Thank you, ma'am.
Can we have Dr. Priya's introduction slide, please? Again, honestly, this is just, trying to even introduce Dr. Priya is actually just a formality because she truly requires no introduction whatsoever. She has done fabulous work. She has made a mark in pulmonology, whether it be ultrasound, whether it be sleep medicine, whether it be anything of pulmonology. She has really made sure that she is a huge achiever and a great knowledge giver. She is the professor at Pulmonary Medicine, St. John's Medical College, Bangalore. She's certified and trained by WinFocus as basic lung ultrasound provider. And that is the reason we are so overwhelmed to have the best teacher with us to teach us the Thoracic Ultrasound Masterclass. She's certified sleep specialist by the World Association of Sleep Medicine. She's also trained in respiratory allergy. I don't understand respiratory allergy and I get absolutely nervous of people who are trained in respiratory allergy. So one more feather in our Priya's cap. She's trained in pain and palliative care also. And she's done multiple research and publications in national and international journals. She's organized and conducted multiple workshops at national and an MD and DNB examiner. I have had the privilege of being a co-examiner with Priya at the DNB Respiratory Medicine, and that's the time I really got to know her wonderfully, even as a person. So in addition to being a huge achiever, she is a gem of a person, and she's a very dear friend of mine who is extremely important to me. So thank you so much, dear Priya, for being a part of our program. And over to you. I look forward to your words of wisdom.
Thank you, Amita. You make me sound so different from what I am. Okay. And actually, we find it very difficult to go through this topic because we have always had one lecture followed by a hands-on training. So everything condensed into a 2 hours lecture makes it sound very difficult, but we'll try to do our best. So can we have the next slide, please? I'm calling it game of a clinical examination. So we know it's called as 2D echo, and the transducer is placed on the chest wall if it's a transthoracic. If it's a transesophageal, the probe is put inside the esophagus, and then you can switch on the M mode, the motion mode, where a single ray passes through and the movement of the tissue under it is read. And Doppler, it can be a pulse wave, color, or continuous wave Doppler. So I think for our basic understanding, M mode and Doppler are not required at the moment. So we will, and no measurements are done. We are just looking at assessing the heart as a pump and making sense out of it to answer some of our clinical queries. May I have the next slide, please? So the probe, as you can see, gives out the radiation, the ultrasound beam in a sector form. It's a microconvex probe, and through that we can see the heart between the ribs. So that's where the challenge is. As Dr. Uma mentioned, the bones don't allow the ultrasound beams to pass through, so they are completely black beyond it. So we have to make do with the intercostal space, try to bend and try to see between the intercostal spaces the heart through it. The next slide, please. So because but there are specific views, unlike the lung, where wherever we put the probe on the intercostal space, we'll be able to see the underlying lung. But here we have to have specific views, and those are classically the parasternal view, the apical four-chamber view, the subcostal view, and the suprasternal view. So for our practical purposes, we will stick to only the parasternal, the apical, and the subcostal view. The next slide, please. So if we are to do the parasternal long axis view, the probe is kept on the second or third intercostal space parasternally, and the pointer is pointing to the right shoulder. So as you can see, can I have the pointer, please? As you can see, the pointer is pointing to the right shoulder, and the ultrasound beam can cut across the heart, like the way we see it, as if it's cutting across the heart and seeing it. So what is seen at this point? Can we have the next slide, please? So we are the next slide, please. So we are seeing the heart from the below the sternum to the, imagine it's pointing to the right shoulder. So we are cutting across the heart like a halfway through. So under our probe is the left atrium, the left ventricle. Can I have the probe? The left atrium, LA, the left ventricle, that is LV, and between the LA and LV is the mitral valve. Then we have above the LV is the AO, that is the aorta, and between the aorta and the left ventricle you can see the aortic valve. And above all this, a small rounded structure that is seen is the right ventricle. So these are the structures that are seen in this view. And here, can I have the next slide, please? And you can see in this view, we can see the heart beating, the movement, the left atrium below, the mitral valve moving, the left ventricle, and the blood gushing through the aorta. So this, and there is a right ventricle which is seen on top. And the bright white line at the bottom is the pericardium. Like Dr. Uma said, like the diaphragm, the change in the medium makes this look bright white. So from the air in the lung to the pericardium, it becomes a change in the medium. So we are seeing it as a bright white line. Can I have the next slide, please? So at that point where the pointer is pointing to the right shoulder, if we twist the probe without making any other movement to make sure that the pointer points to the left shoulder, we will be cutting across the same view. Imagine if we have cut across a longitudinal section. Now we are doing a cross section. So this cross section, if you point it to the foot end of the patient slightly, tilt the probe to the foot end of the patient, gives us one view, vertically down gives us another view, and a bit towards the head end if we shift gives us another view. Can I have the next slide? So in the parasternal short axis view, across, we pointed towards the leg end. You can see the papillary rounded structure is the left ventricle, and the papillary muscles are seen as small white structures within it. Can I have the next slide, please? And you can see it is contracting like this nicely. And a bit, if you tilt the probe on top, you can see the left ventricle again at the same place as a rounded structure, and the small opening that is seen within it is the mitral valve. So this is like a fish mouth. Can I have the next slide, please? So here you can see the left ventricle, the right ventricle, and the left ventricle with the mitral valve in between. Can I have the next slide? Yeah. Can I have the next slide? Yeah. So if we tilt it a bit on top, here we see what the left atrium, the left ventricle, and the aorta is seen very nicely. And this is the like a Mercedes-Benz. So this is called the Mercedes-Benz sign. The three cusps of the aorta are seen here. Can I have the next slide, please? So the next would be a apical four-chamber view. We come down where the apex is palpated at that point. Suppose the fourth or the fifth intercostal space. We try to look at the head end of the patient. You can imagine you're cutting across the ventricles and looking at the top. The advantage of this view is we are seeing all the four chambers. So the name says it all. You're keeping the probe at the apex and you are seeing all the four chambers of the heart. And here the pointer is pointing to the left of the patient. Can I have the next slide, please? So this is how things look like. You can see where the probe is kept, and you can see the left atrium, the left ventricle, the papillary muscles are seen, and the interventricular septum is seen, and the tricuspid valve is seen. All this can be appreciated. If we tilt it a bit, you can see the aorta can also be seen as a separate opening. Can I have the next slide, please? So these are the four chambers that are seen. Next slide, please. So you can see the left atrium to our right. We can see the left atrium, the left ventricle. You can see the left ventricle contracting, and the right ventricle, which is smaller than the left ventricle. And the left ventricle seems to be contracting into the center. So all the four walls have to come together. So if that's not happening, then there is a problem. So you concentrate on the interventricular septum, whether it's moving towards the other wall and the bottom portion of the heart coming up. All this has to come like this. So if that's not happening, there is a problem. And the pressure in the left ventricle is higher than the pressure in the right ventricle. So the interventricular septum is bowed into the right ventricle. So these are some of the important things that we see in this view. This is relatively an easy view to demonstrate when we start off. So the moment we start off, if we can demonstrate this view and get at least 3.5 chambers like what's seen here, we have managed to answer quite a lot of questions for our patient. If you see this is a normal heart contracting. So you know your patient doesn't have it answers a question. Patient doesn't have a left ventricular problem. Patient doesn't have a right ventricular overload. So probably the patient's cause of symptoms is somewhere else. So there is the interventricular septum is moving well. All the walls are moving well. That's all we need to answer. We are not looking at a small regurgitation, a small defect. That is not the cause for the severe breathlessness that a patient is having. We are not replacing a cardiologist. We are not giving any numbers to it. So we don't need anything more than being able to generate a full image like this. Can I have the next slide, please? So the next view that is relatively very easy is the subcostal view. You keep the probe in the subcostal angle, just below the subcostal angle. Use liver, as you can see at the top of the screen, liver as the window to look into the heart. So imagine like the way we used to palpate for the right ventricular apex coming and touching our finger. So imagine you put your probe, ultrasound probe into that and look into the heart. So this is a bit difficult in a person who's very obese, but we can manage to generate a good image in the early stages. I think this would be another easy way to assess the ventricular function. Basically, look at how the left ventricle and the right ventricle are behaving. Can I have the next slide? So you can see how it looks like. The top where the arrow is pointing is can I have the arrow? The tissue on top is the liver. Yeah, above, a bit higher up is the liver. And yeah, that's the liver. The below the liver is the right ventricle, and below that is the left ventricle. So we can see the right ventricle is small, left ventricle is bigger, and it's contracting pretty well. Can I have the next slide, please? So now, if we are to do an M mode, why would we do it? You can see, compared to the previous image, this one, you can see how the ventricle is contracting. On the left side is the parasternal long axis view. If we drop a single line, you can see a faint green line. So one single beam is coming through that side from top to bottom, and the movement across that is shown in the form of a wave on the right side of the screen. So if we see a ventricle which is contracting nicely, the wave would be like this. And the ventricle which is not contracting like very well, the wave would be sluggish. So that's really common sense. We don't need a great knowledge to say that a ventricle which contracts like this is a good contracting ventricle, and a ventricle which is not contracting well will be a sluggish ventricle which has got a left ventricular dysfunction. Can I have the next slide, please? So if you see this, it's very obvious. This is a apical 4-chamber view in which, can you press the video again, please? So in which you can see that the septum is moving towards the left ventricle and is not moving in one go. So it's moving in parts. So there is a septal dysfunction. So probably a regional wall motion abnormality with the pressure on the right side, which is higher. So the right ventricle, you can see, is bigger than the left ventricle. To your right is the left ventricle, to your left is the right ventricle. Can I have the next slide, please? So this is one of the questions that we asked. The tricuspid annular plane systolic excursion, that is TAPSE, which is one of the measures of right ventricular dysfunction. So this also, you just drop an M mode beam which touches the right ventricle, and at the point where the right ventricle is in contact with the tricuspid valve, and you can see the movement of the tricuspid valve up and down. If the ventricle is contracting well, the movement will be quite a lot. If the ventricle is not contracting well, the movement will be reduced. It's as simple as that. The height determines the contractility of the ventricle. Next slide, please. So can we play the video? Yeah. So any doubt about the left ventricular dysfunction? You can see how lethargic ventricle is, the M mode below, and the movement of it is not pumping in like this, and there are a lot of regurgitant lesions, regurgitation happening. So we are sure this is a left ventricular dysfunction. Can I have the next slide, please? And a detailed history will tell us what's happening. So this is a parasternal short axis view. See how the left ventricle is. The rounded structure has become a D-shaped structure. So very obviously, the pressure on the right side is higher than the pressure on the left side. So the ventricle is, the interventricular septum is contracting into the left ventricle. So the pressure on the right side is higher, which is a sign of right ventricular dysfunction and a sign of pulmonary hypertension. Next slide, please. And what is there over here? You don't need great brains to say that the ventricle is contracting, but it is hypertrophied. Where is the space for the blood to flow through? Both the ventricles are touching like this and they're terribly hypertrophied. You can see the left atrium is like a ball sitting on top. So this is definitely a left ventricular hypertrophy. Whether this is the cause of the patient's symptoms or not, you have to use your common sense and other supporting evidence to find out the answer. Next slide, please. And what's happening here? This is a heart for sure. But what's happening to the heart? It seems to be dancing on a trampoline. And you can see the left ventricle at the bottom, the right ventricle on top. The right ventricular wall is moving in and out. So this is a pericardial tamponade. If this is there, you don't have to really strain to find the heart. If you put your probe in the subcostal area, the first thing that you will see is the heart immediately, because the fluid around the heart acts as a good window to see the heart. Otherwise, you may have to strain a little, but if there is fluid, you will see it very well, though it's not a good sign, but at least you get an answer to why is the patient breathless. So this is a pericardial effusion with a cardiac tamponade. You can see the right ventricular valve moving up and down like on a trampoline. Can I have the next slide, please? So can you see what's, can you click on this? There is a video. This is something moving within the left ventricle. These are our own videos. We've not recorded it. This is not from the echo machine. So you can see there's something moving within the ventricle. So if the patient is hypotensive and you see this, you know the cause, or you are in the emergency and there is always a tiff between a cardiology resident and a pulmonary medicine resident saying where the patient belongs. If we see this, definitely the patient is not solely our responsibility. So you have an answer as soon as you see the patient. If the patient is hypotensive, then you know it's not only sepsis or only something else causing the problem. It could be this clot within the left ventricle, which is the cause of the patient's problems. Next slide, please. So now coming down to the next organ, that is the diaphragm. A breathless patient, you don't know, you've done all the investigations, everything seems normal. The next thing is the diaphragm involved. So we all know the anatomy of the diaphragm. Can I have the next slide, please? So the transducer that is used for this is a curvilinear probe and a linear probe. So the curvilinear probe tells us a lot of things about the depth, and the linear probe tells us about the superficial structure, which is very well defined. Can I have the next slide, please? So like the way we did with the echo, here again we use the liver as a window to see the diaphragm. So Dr. said diaphragm will appear as a bright white line. So we are aiming at seeing that bright white line through the liver as a window and seeing for the movement of this bright white line. So, and you can see how it looks like what we are trying to see. And for the initial period, it's good to look at left side alone. But as your expertise increases, even on the right side alone, as your expertise increases, through the spleen, you will be able to see the left diaphragm also. So both the measurements are possible. For the initial period, it's good to do only on the right side and see for the excursion of the diaphragm. And next slide, please. So this is how, is it a video? Could you please click on it? And a single movement of that line up and down on the single line is what is seen on M mode. Can I have the next slide, please? The next slide, please. Can I have the next slide?
Dr. Hardik, can we change the slide, please?
The next slide, please. The tech team.
Yeah, the slide moved. It's come to measurements diaphragm.
Can I have the next slide? The slides are not moving.
Okay, now it's moved.
The slides are not moving.
Okay, you want to just wind up because even the time is over. We can go to the next one then.
Can I have the tech team, please?
Dr. Hardik, is this correct, Dr. Priya, this slide?
Yes, ma'am. The slides are moving, ma'am.
Hello?
Dr. Priya, they are seeing the slides are moving.
Okay. Yeah. Now it's moving. So if the M mode is put, you can see the movement of the diaphragm up and down, and we can measure it. We measure it with 3 manuals, that is on quiet breathing, on a sniff, or a deep breathing. So these are the values. Probably in the initial stage, it's good to be able to even generate these images. If we are able to do it, then we can do the measurements and interpret it and take clinical action based on this. Next slide, please. I can't see the slide moving.
Dr. Priya, I was just thinking,
Yeah.
you want to just wind it up without the slide because time is up. We need
Yeah,
to.
sure.
Yeah.
So then I'll just show, can we move a few slides? I'll show the linear probe and be done with it. So thickness and thickening fraction is measured like this at this point with a linear probe. And can we have the next image? Yeah, so this is how the diaphragm looks. The left hand side is the lung which is coming in, and the right hand side, the 2 bright white lines are the diaphragm. So the thickness can be measured in deep inspiration, expiration, and the thickening fraction calculated. I think we can wind up with this.
Okay. Great. Thank you, Dr. Priya. This was a fabulous talk. I've never learned echo so well, and we are sorry for some of the slides that were not moving, but a wonderful talk, very, very informative and knowledge giving. After this, we'd like to go back to Dr. Nishant's talk. Dr. Nishant, we apologize for the initial problem with the platform. And I've already introduced Dr. Nishant. We all know that he looks very young, but he's a master of ultrasound. And I feel very, very blessed that I got to know him during a BronchoCon Silver. And since then, we make it a point that every ultrasound or EBUS workshop that we do, he's always our faculty because he's a complete expert. Over to you again, Dr. Nishant.
Yeah, so I think, hi everybody. He has to share my slides because this time I have given it to him now. All his doing. Please share the slides, yeah.
Yes.
So, yeah, next. I'll just speak next, okay? And you keep moving. Next, 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 So I think I was up to here when it got crashed and we had to go off.
Yes.
So there are 3 probes. Already I have spoken on it. Next. Yeah. So gain is basically I was started with the
May I
basic of
request,
gain. Next. Next.
Dr. Nishant, would you like to talk about the probes? Because I think people
Yeah.
could
Okay.
not
Go
hear.
back. Go back.
Let's
go back.
start with the probes because
All
lot
right.
of
Good. Go back. Yeah.
people want to know the probes.
Go back. Go back. Yeah. So yeah, very basic talk. I'm going to talk very basic. Next. Next. Yeah, so basically there are 3 probes which we use. One is called linear probe, another is curvilinear probe, other is phased array probe. So if you see in the right side of this screen, there's a graph where y-axis you are trying to see the penetration and resolution. In the x-axis you are seeing the frequency of probe. So very beautifully mentioned here that if you see phased array probe, it has got the frequency of 1 to 4 megahertz, where it is penetrating little more than curvilinear and straight probe, and also it has got lesser resolution. But as you increase the frequency, the resolution increases but penetration decreases. That's the basic of ultrasound, and this is what you have to remember in your work when you're doing. So if you take phased array probe, it has got a narrow footprint. That means it cannot see wide like this. It has a narrow footprint, but it can go deeper because it is lesser frequency. If you take curvilinear probe, it has got a wider footprint. That means it can see a little wider, but at a cost of low frequency, it can see deeper, but not much superficial. I hope I am clear. Next. So gain is basically done by the machine. It helps us to amplify more better the deeper reflected waves and lesser the superficial reflected waves. So the machine mixes all this and give it to us as the final signal, which is called grayscale. I'll come to that in the next slide. Next. So this is the exact picture showing same. If you are plotting on the x-axis distance from transducer, and if you're plotting on the y-axis amplitude of the reflected signal, you see it very carefully that if the signal is coming from 5 centimeter depth, it is more amplified done by the machine itself, and that's how the grayscale comes. Grayscale. So if it is more gain, suppose you are very busy and you didn't check the gain and you put the probe on the patient, there was a pleural effusion, but everything else looks black. So you need to adjust the gain there and look at the black part of effusion and other gray areas like liver and all and diaphragm, so that you can make a difference of what is what. Otherwise, everything will look black. Next. Next, this is called time gain compensation. So if you see in the ultrasound machine in the left side, there are 8 bars, which is you might be seeing in your machine 8 bars. Each bar is equal to 1 centimeter. So if you see the lower part of the bar, the time gain compensation is more because you need to reflect the deeper waves more. And that's what is this x and y axis showing same thing. Next. So this is what I was saying. So if you see in the left side, there is a and the ultrasound image is very black because gain is less. But in the right side, you can see B lines, same patient, you can see B lines very clearly because they have taken better gain in the lower part of the image. Next. So can you play the video, please? Okay, leave it. It's not playing. So the same thing is being the video here. If you take less gain, you can't see B lines. But if you take the optimum gain, right side video, please, you can see better B lines because you adjusted the time gain compensation in the lower part of the image, and you can now see B lines very clearly. That's the importance of time gain compensation adjustment. Next. This is again same thing I've told. In the middle, in the left side of the figure, in the middle part of it, gain is taken very less, so you're seeing black. But when you optimize the gain, you are seeing everything better in the grayscale. Next. So this is what it is. What is optimum TGC? Optimum TGC is what you want and what suits better to you. So in the upper part of the image, take less gain. In the lower part of the image, take more gain so that you can see everything better. Next. So this is what it is. All of us are different. All of us may want different, gain levels, but this is the actual ideal gain to be taken. In the extreme left of the figure, we are seeing the grayscale reference, and the right side B is the liver, which matches that. A is the effusion, C is the spine. So you can just see how gain adjusts to all this. And this is what in the B mode, we try to look at the ultrasound image of the structures when you are doing the ultrasound. Next. So depth is nothing but it's a part of next thing. you need to adjust the depth when you're trying to look at the ultrasound for the structure. So if you're using a curvilinear probe, it can see deeper, and the straight probe, transverse probe, can see superficial. So you need to adjust the depth so that you can see the things best. So the rule of thumb is start with the higher depth, then decrease the depth so that your area of interest is at 3/4 of the screen, so that you can see everything. Like suppose there's a fusion, you want to see fluid, you want to see diaphragm also. So that's the importance of depth. Next. So this is the same thing. This was as marking for thoracoscope. So you can see here depth, how it works out. In the left hand side, you are seeing 1, 2, 3, 4, 5, 6. So diaphragm is coming at 5 or 6 centimeter. So if you just want to see effusion now, you can just reduce the depth and just see effusion. But ideally, I want to see diaphragm also. So this is my optimum depth where I can see everything. And the left side, you're seeing the collapsed lung also. So that's the importance of depth. If you take too low depth, then you may not see a lot of things deeper. If you take too high depth, you can only see superficial structures. So you have to be little judgmental for that. Next slide. Yeah. So focus is nothing but it's a part of depth. It is the part of your screen which you want to concentrate most. Suppose you want to do a biopsy of a lesion, or you want to tap a loculated effusion, then you adjust the focus at that. It is contained in the depth, so it will adjust. Some machines adjust it, otherwise you have to adjust it. Next. So this is again, contrast is what basically contrast is for the screen, and gain is for the structure in the screen. So ideally, when you are doing the ultrasound, you don't need to look at the contrast much. It's all adjusted. You have to just move forward for the gain, not the contrast. Next. So I told already difference between gain and contrast. Gain is for the ultrasound specific structures in the image. Contrast is for the screen brightness. Next. Again, there's a very important topic called resolution. Resolution is when you can identify two structures as different. So I told already, if you're using a high frequency, you can have good resolution, but you'll have low wavelength. Next, it can't go deep. Next. So this is the example here showing same thing, that as the waves go in and they come back, they summate to give us the picture of what we are seeing as black and white in the lower part. Next. So here I'll spend 1 minute. So if you see there's a high frequency probe which is going, you can see the upper part of the structure very clearly, but you can't see the deeper part. But when you use a low frequency probe, you can see the deeper part better as compared to the high frequency. So in this picture, this is the middle one is a high frequency probe, a high ultrasound probe, and the lower one is low frequency. So that's the meaning of frequency and how you select which frequency to use. Next. So this already I have told. Next. Now coming to Doppler, again very important. Routinely in our work we use two modes. It's a very basic slide which is called color Doppler and power Doppler. You should just remember BART, blue away and red towards. There's nothing like blue is artery or red is vein, nothing. If the ultrasound probe, the vessel, the blood is flowing away from the probe, it will appear blue. If the blood is flowing towards the probe, it will appear red. Another important thing, if the blood flow is at 90 degree to the flow of the wave, you won't get Doppler signal. If it is parallel to it, it is 0 degree, then you'll get good Doppler. Next. I just told that same thing being told here again. So what Doppler shift we are seeing is the angle. So basically cos 0 is equal to 1. So if the blood is flowing parallelly to the ultrasound beam, you will get good Doppler signal. But if it is flowing at perpendicular, you won't get Doppler. And if it is between these two, between 0 to 90 degrees, you will get whatever weak and strong Doppler signals. Next. There's next Doppler is called color Doppler. It's very important when you are trying to puncture intercostal, space for pleural tapping. So all of us know that the blood vessels come at the lower part of the rib. So we always need to puncture at the upper part of the lower rib. And these blood vessels are hidden in the groove. Normally they're not seen. I don't see, but sometimes you may see in old patient, thin patient. So try to look for it. And there, after putting the color Doppler, always put also put the power Doppler. You can see the actual color of the blood vessel. And depending on if you are able to see the vessel, then you should not puncture there because it will cause bleeding. So if you are lucky, you may see this. Otherwise, you may not see routinely. Next. So once you have done color Doppler, also put the power Doppler. Power Doppler will give you a signal like yellow-orange scale, not the red one. So it is more sensitive than color Doppler. It can also pick up less blood flows, and you can be more sure that there's a blood flow going around. Next. Now coming to modes, B and M mode. Next. So the routine ultrasound which you are using is a B mode. B is just nothing but it's made by the company B letter. It's called brightness mode. The same thing is called 2D mode in Sonosite and Philips, but in the G mechanics it's called B mode. So it is the conventional two-dimensional grayscale image which I showed you earlier. That's called B mode, which we use initially with the curvilinear probe. That's called B mode. Next slide, please. Then comes the M mode. M mode is defined as a motion versus time display mode along a chosen line. I'll show you in the next slide. Next. Here I'm going to spend 1 minute. So basically, if you see this, is very, very, very important. M mode and B mode. So in the right side of the image is the B mode, and M mode is when you put the M mode signal, there's a dotted line coming up in center. Basically, M mode is that slice of the image which is being projected in the left side, and it ignores everything else in the B mode except that line where the cursor is there. So you have y-axis and you have the x-axis. On the y-axis, you can see subcutaneous tissue, muscle, pleural line, and it correlates with the B mode in the real time. So how do you do it? There are steps, but just you have to press on the M mode, wait, then again press once more, then it will start working. Like we see for pneumothorax, that's called stratosphere sign. So this is just to show that. Next. This is the last part of nomology. You need to freeze. Once you have seen your structure, freeze. You need to measure. And the most important is you need to capture your video. Otherwise, you won't show in the meetings or conferences. All of us forget when there's difficult case. We are very busy. We just go do it. And then we forget to capture the image. Also, the problem is we cannot push the videos in our EMR or PACS because that age has not yet come. But I think we should be able to do it in future, next few years. So I come to the end of my talk. That's it. Thank you. Next.
Thank you very, very much. Yeah. Dr. Nishant, thank you very, very much.
Done.
In fact,
7 minutes.
Yeah, I know you really fast forwarded your talk, but I basically feel you made it very, very simple. And though you went fast, it was very, very easy for me as well as everybody to understand how to know your probes, how to use our ultrasound machine in the best possible way in various situations so that we can best diagnose conditions. And thank you for making this topic extremely simple for us to understand. Thank you so very much. So after this, basic introduction to all the basic things that we need to know about ultrasound, which were the normal stuff. Now let's start going to what is actually abnormal. So for this, I would like to invite Dr. Uma to tell us about dyspnea. I mean, if a patient comes with breathlessness, how are we going to approach the patient? Just a request, all the talks are extremely informative, very, very entertaining, but just the time is running. So if we can keep it short, it'll be great. If we can finish the talk in maybe 10 to 12 minutes, it'll be super. But up to 15 minutes, okay. But if little faster, great. And at the same time, before, I just want to say a huge big thank you to Dr. Hardik, who has been around over here. He's been helping each of us with the presentations. He's put in so much of efforts to make sure this webinar came across extremely enthusiastic, and huge thank you to dear Dr. Hardik from GSK for being our partner. And I also want to say that Dr. Yogesh from GSK has been here, and he also has been extremely helpful and extremely enthusiastic in making sure that this webinar comes across extremely well. So big thank you to both our doctors, and over to you, dear Uma.
Okay, so just a recap of the lines and profiles. So I hope even my cursor is visible. So here you can see this is the A line which we were mentioning. We've seen in the previous presentation, and this is the bat wing sign. So here we can see this is the loss of lung sliding. We can see the whole part of the image which is moving en masse together. This is the loss of lung sliding. Whenever we see loss of lung sliding, we should always think that probably there is a underlying pneumothorax. But mind you, lung sliding loss doesn't mean that there is definitely a pneumothorax, because many other conditions can cause loss of lung sliding. For example, if the person has undergone a previous pleurodesis, or he has a massive pneumonia, so much inflammation that the lung is stuck to the chest wall, there again we will not see any lung sliding, say in ARDS. So there are few instances where we might not see the lung sliding, so we have to be very mindful of it. Only if we are able to identify something called as a lung point, where say, it is exactly where the collapsed lung in a pneumothorax is coming and touching the chest wall. So when you put a probe at that particular point, you can see one half of the image where the lung sliding is happening very beautifully, and the other half there is no lung sliding. So this is called as the lung point. I will show you in my subsequent slides. So this is the consolidation. This also I have explained before. So this part is the shred sign, and in the middle you can see the white dots. These are the air bronchograms. So as I was telling, this is the lung point. We can see very clearly in this image, one half of the image where there is no lung sliding, where my pointer is pointing. This part where the lung is not at all moving. Okay, it is just, there is minimal movement, but this is moving up along with the chest wall as such. And the other half of the image, you can see that fine movement of the pleura where it is shimmering very well. So this is exactly the point where the collapsed lung is touching the chest wall, and we are able to identify this with a ultrasound probe. So this lung point, if we are able to see in a patient, this 100% tells us that there is an underlying pneumothorax. So this is a picture of an effusion. So here we can see this is a sector probe. You can see this is the skin and the underlying muscle and lung subcutaneous plane. Here you can see completely anechoic area. So whenever we see black on the image, completely black means fluid. So this is a fluid. This is pleural effusion. Here you can see this bright white structure. This is the diaphragm, and something dancing in between here. This is the collapsed lung, which is fluctuating and fluttering inside the pleural effusion. This is called as a jellyfish sign, like how the jellyfish, it is moving inside a sea. This lung is also floating in and around the fluid. So this is called as the jellyfish sign. So all pleural effusion will appear as black in the ultrasound image. So this we have to keep in mind. So now when a person presents to us with dyspnea, just by use of the ultrasound, like how Dr. Priya also said, and a basic echo, we will be able to identify almost many of the pathologies listed here. Like for example, if you're able to identify a lung point, this person is dyspneic because of a pneumothorax. Or if you see a massive effusion, completely black and anechoic fluid, you know that this person has pleural effusion as a cause for his dyspnea. If you see that the patient is very dyspneic but lung ultrasound is normal, both sides there are A profile, there is no problem, then you know that probably this person has a airway obstruction. Mind you, always we have to interpret the image like how we interpret the X-ray or a CT with the patient's history and the background in mind. Always history and the examination, clinical examination plays a major role. Based on that only we will interpret our ultrasound. So we'll come to the interpretation. How do we interpret? For interpreting a person who's coming with dyspnea, exactly if you keep your ultrasound probe in these 6 points, what is called as blue points, is very simple and complete. We can complete the imaging within few minutes. Just 3 minutes is all it takes to put your probe on these points, as well as complete your DVT. You can see the red dots on the groin also. So you can just have a brief look at the veins also, whether there is a filling defect, whether there's an underlying deep vein thrombosis, and of course a basic echo. So this will complete our evaluation for a dyspneic patient. So first report was done by Dr. Daniel Lichtenstein. He did a study in 260 patients and brought out what is called as the blue protocol, bedside lung ultrasound in an emergency. So we need to be aware of what is called as the blue points. Here we can see in this image how the person is having both his hands on the chest wall. This is the upper blue point where it is between the meeting of the fingers, at the base of the fingers. The lower blue point is over here, and this line is the Fredic line. This is where the diaphragm will come, and just beneath that, along the Fredic line, posteriorly, the most posteriormost part which we can see, this is called as the Plapp's point. So this will tell us the upper and lower blue point, lung points. We can identify whether there is any interstitial syndrome, or if there is a pneumothorax. Always air will point, it will go up, point upwards. So upper blue lung point, we can see whether there is any pneumothorax. The phrenic point will tell us information about whether there is any one lung intubation or an esophageal intubation. At the flaps point, we'll be able to identify these pathologies like pleural effusion or consolidation. The profiles already I have given a brief intro in my previous presentation. So let's directly jump into the cases. So case 1 is a 55-year-old known case of COPD. So far on medication was stable, but now presenting with worsening breathlessness. ECG and echo showed that this person has a dilated cardiomyopathy and was in failure. Already has been treated for the failure for past 6 days, but still there is some dyspnea. They are not improving. So all of us have faced this. We always have a fight between the cardiologist and the pulmonologist. Cardiologist will say, no, this is the pulmonary problem, COPD is the cause, and we'll say, no, this is the cardiac cause. But no need to fight anymore. Our ultrasound will definitely solve our issue. So if you see a ultrasound image like this, what is seen here, we can see this is the sector probe. You can see the sector type of image, skin, subcutaneous plane. This is the bright white pleural line. You can see how the pleural line is smooth. It is not irregular. It is not broken. And from this, you can see the rocket-like V lines. And it is flooded. So it is like a white-out lung. The lung is flooded. If you see a picture like this, you know that lung is very wet. So this type of V line, the lung is very wet. So a very methodical approach we can see. Always when we do the lung ultrasound image, we have to first note whether the lung is sliding or not. In this image, you can see that the lung sliding is present. What is the profile? So there is lung sliding and there is V line. So this is a V profile. So when you see that the patient is dyspneic plus extensive V lines on both sides, then straight away you know that this person is having pulmonary edema. You can go and do a brief cardiac ultrasound and see what is the cause of pulmonary edema here, the dyspnea. So this is how a pulmonary edema can be identified. Case 2, this is a 36-year-old lady. She presents with progressive dyspnea of 4 months duration, but had no prior history of cough or wheeze. She was hypoxic. Room air saturation was 82%. She had no chest pain or no leg swelling. So this strongly we will always think in a person like this, we will think of pulmonary thromboembolism, isn't it? So let us see how ultrasound is going to help us. So when you do the ultrasound, this is the transverse view. You can see this is the linear probe. You can see the straight type of footprint here. This is the subcutaneous tissue and the muscle layer. Here you can see the pleural line, the bright white structure, and nicely it is moving. 1 or 2 A lines are coming here. So this is a normal ultrasound, isn't it? Lung sliding is present and A lines are present. This is A profile. Okay, A profile. So if you see A profile, that means lung is normal. So next, but patient is dyspneic and patient is hypoxic. We do a venous scan. In the venous scan, if we see the veins are not compressing, here you can see this is the vein. The veins are not compressing, and you can see a echogenic, bright white, hyperechoic structure here. This is a venous thrombosis. So if you are able to see a venous thrombosis, plus the patient is dyspneic and a normal lung ultrasound, A lines are there, then you know that the cause of the dyspnea in this patient is pulmonary embolism. Okay, so we did a CT scan in this patient, and here you can see the massive embolism in the main pulmonary artery. So let's move on to case 3. Here is a 60-year-old male, known case of COPD and IHD for the past 5 years, presents with worsening dyspnea for the past 3 days. So let's see how ultrasound is going to help us. This video is not moving. Okay. So here you can see this is a sector probe. You can see the skin and the subcutaneous plane. And a smooth pleura here. This is the rib shadow. Okay, the black shadow. This is caused because of the ribs here. You can see this is a normal lung, isn't it? The pleura is moving and there are no V lines. So if you see a normal lung, this is a lung sliding is present and A line. So this is an A profile. Next, we did a DVT scan, but that is also negative, normal veins. So we have to look at the flaps point. We should never forget to look at the flaps point. Flaps point is also normal. So if you see that the patient is dyspneic has a background history of COPD, but lung ultrasound is absolutely normal. There's no fluid in the collapse point. DVT scan is also normal. Probably this person is having an exacerbation. Even in a sinal chest, you can pick up that this person is having an exacerbation of COPD or asthma. So next scenario, same patient, if you see that the lung sliding is absent. Lung sliding is absent. So, but there are A lines. So this is an A profile. No B lines. If the lung sliding is absent, we have to look at the lung point. Okay. If you are able to identify the lung point, so here you can see this half of the image, there is no sliding. Okay. And only intermittently you can see the lung is coming and touching here. This is the lung point. Okay. There is just movement only when the lung is coming in, touching the ultrasound probe area here. So this is the lung point. This person's dyspnea is because of a pneumothorax. So for the pneumothorax, mindful, we have to first note whether the lung is sliding or not. If there are B lines, it negates the presence of a pneumothorax. So B lines, if you see, that means absolutely there is no pneumothorax. Again, if you're also able to see a lung pulse is nothing but I'll show you in my further slides. If the lung is collapsed, okay, you can only see the pulsating movement because of the reflected cardiac pulsations. So that is called as lung pulse. If you see a lung pulse, there again it says that there is no pneumothorax, it is a lung collapse. So no lung sliding doesn't mean that there is pneumothorax. Okay, there are other conditions which can cause reduced lung sliding like apnea, or if there is a selective intubation only into one lung, the other slide part of the other hemithorax might not show any lung sliding. Or if there is a massive pneumonia, a lot of inflammation, the lung is stuck to the chest wall, you might not get any sliding. Okay, so here is another patient who's very dyspneic. So you see the lung ultrasound, you can see a nice A profile. Okay, lung sliding is present and A lines are present. Okay, so this is an A profile. You do a DVT scan, but the scan is also normal. Normal veins are there. Next, we look at the collapse point. In the collapse point, if you see a effusion like this, massive effusion, and you also see a jellyfish sign, anechoic image with a jellyfish sign, you note that the cause of the dyspnea in this person is a pleural effusion. Okay, same thing. If you have a dyspneic patient, any lung sliding, whether lung sliding is present or not, but if you see a C profile like this, okay, massive, you can see a lot of shreds here, you can see air bronchogram here, then the cause of dyspnea in this person is a consolidation. You can also see the liver. You can see how the curtain sign is not that very evident here. Though the lung is and the liver are moving, it is much reduced. The movement of the liver is much reduced because of the massive consolidation. So moving on, if you see lung sliding, there are A lines. This is an A profile, but there is no lung point or no shred. Okay, and you do a M mode in this. M mode is nothing but you have a single ultrasound beam dropping here. Okay, and you can see that the lung is pulsating. So the only movement across this ultrasound beam will be detected. You can see these vertical lines. This is exactly the cardiac pulsations which are visible like this. If you see a picture like this in the M mode, this shows that this person is having a collapse, lung pulse. If you see, the collapse is the cause for this person's breathlessness. Okay, to summarize, if you see bilateral A lines in a dyspneic patient, probably causes dyspnea due to asthma or COPD. Okay, if you see focal multiple B lines, then cause of dyspnea is probably either a pneumonia, embolism, or atelectasis. And if you see diffuse multiple bilateral B lines, then you know that the water content in the lung is more. Probably the dyspnea cause is pulmonary edema or an interstitial pneumonia or ARDS. Again, if you see diffuse multiple bilateral B lines, you do a cardiac ultrasound. if you see a good contractility versus the poor contractility as shown in this picture, you just briefly have a look at the valves, whether you can even put a Doppler and see whether there is any MR or TR, and you can look at the IVC. If the IVC is collapsing nicely like this, and heart also is showing good contractility, then the cause of dyspnea is non-cardiogenic. There is some other cause. Whereas if you see a poor contractility and IVC is also not collapsing, then you know probably a cardiac failure is the cause of dyspnea in this patient. Okay? So there are few pitfalls in the blue protocol. If you use the blue protocol exclusively, only blue protocol, it might not be able to differentiate between ARDS or pulmonary edema. If you see a C profile, again the C profile does not differentiate between infarction and pneumonia, but there are a lot of other methods and other ways in which, even with the help of ultrasound alone, we'll be able to differentiate between ARDS and pulmonary edema. And so this blue protocol and approach to dyspnea is best applied in the early stages of respiratory failure, especially in a person who's critically ill, right in the ICU. You can use the ultrasound is of immense use. We can apply it even you don't need an X-ray or a CT scan. We can identify at the bedside what is the cause of dyspnea in this patient. So the future is here. You can use your ultrasound in your day-to-day practice to identify the cause of the underlying pathology in your patients. Thank you so much.
That was
Over to you,
fabulous,
Amita.
Dr. Uma. That was just wonderful. And I think basically currently, if we know how to do ultrasound, then probably stethoscope and chest X-rays may just not be required. This was amazing. Thank you so much. This was very, very enlightening. After this, I'd like to now invite Dr. Priya. And Dr. Priya is going to tell us about, how to manage a patient, not only of ARDS, but any patient who's in ICU, hypoxic, hypotensive, how to manage with the help of using ultrasound. Over to you, Priya.
Yeah. So,
Can we have the presentation, please, Dr. Hardik?
no, I think he's asked me to share the presentation.
Okay.
So I'm sharing my.
Can you check if your slides are moving, please, Dr. Priya, before starting? Can you try to shift your slides and see if they're working?
Yeah.
The slide share has gone away now.
Is it seen now?
Now we can see it, yes.
Yeah. So go straight away, since we've had a discussion on what all we need to do and how which probe to use. So
Yeah, let's try to finish it in 12 to 15 minutes. That'll be
yes.
great.
Yes.
We have like
So
some 32 audience questions also.
Yeah, a quick review of a patient who's presenting to the emergency with fever, breathlessness, hypoxic, hypotensive. So how do we help? So role of ultrasound in this patient would be to, because he's hypoxic, we may need to intubate. So when we intubate, we have this is how an endotracheal tube within the trachea would look like. And if we manage to get into the wrong tube, a double tube is double trouble. So we don't need to wait to inflate, check for the hard sounds. You landed in the esophagus, you can do it immediately. As soon as you go in, or as you are going in, you can identify that we've done the wrong intubation. Or you can just inflate the carina with inflate the endotracheal tube with saline, and you can see the position of the cuff also very clearly. And we've seen this. You've diagnosed ARDS in this patient if at the PLAPS point we see a consolidation, or as we are examining the patient with our stethoscope, you see something like this, that is the A lines. That means we are not looking at a pathology which is directly related to the lung. We have to find out something more, versus this, a small peripheral consolidation versus a massive consolidation. This is like we are looking into the liver. It's not the liver, it's the lung. This is the, instead of air bronchogram, this is the fluid bronchogram. Is suggestive of a hepatized lung. We are very well aware of hepatization of the lung in the pathology, here also we see the same thing happening. So now we've put this patient on the ventilator. He starts off with this. There are a few B lines seen. To imagine if this is seen the next day, so patient has definitely deteriorated. We don't need to do an X-ray. As you're doing rounds, you go see the patient. This shows nicely these specks are moving. So a fluid bronchogram or a dynamic air bronchogram is seen. If this is seen, it's a consolidation and not an effusion, not a collapse. So, or versus this is seen. So this is like a whiteout lung. You're seeing a lot of, this is a shred. So this also suggests a consolidation. So monitoring, how do we do? Imagine a patient goes from a minimal consolidation like this to an extensive hepatization or vice versa. So we can monitor them on a day-to-day basis. Imagine if you draw these, put these signs and put the findings in each of them, monitoring becomes very simple, and you can transmit the same image to the next person also. Or you see this. This is, there is no lung sliding, and at this point, half there is lung sliding, half there is no lung sliding. So a diagnosis of pneumothorax is made on a person on a ventilator. So instead of only auscultating, if we do this, our questions are answered what next to be done. And or we see this, a classic D-shaped ventricle. This is the mitral valve seen within it. Pressure on the right side is high, so the interventricular septum is bulging into the right ventricle. So this patient, if this finding wasn't there yesterday and it has come up today, you know has developed a pulmonary embolism. Look at the veins. If there is a clot there, or you can start on treatment immediately without even asking for a CT-PA. Or look down into the abdomen, you see this. So this is the clot within the IVC. You can see a compressed liver, probably a cirrhotic liver with this. So somebody has asked, what is a Plapp's point? It's the posterior alveolar point that is at the back, the lowermost and the backmost point where you can insinuate your probe in a patient supine in a ICU, where you look at the lung between the diaphragm and the lung to see if there is a point, and that is the point at which ARDS begins. So I think I'm done with my presentation. So beginning with a person who's hypoxic and this. So somebody is asking, are there specific maneuvers, specific positions? No. It is like clinical examination. There are no specific maneuvers done for the lung ultrasound. For cardiac, yes, there are specific maneuvers to be done because you have to visualize a static heart. Lung is a huge organ. You can do it wherever you want. I think I'm done with my presentation. We can move on. So I think the next talk is by Dr. Nishant.
Yeah. Dr. Priya?
Yeah, I think.
Yeah. Sorry. Yeah. I think I'll ask questions later. So first we'll do Dr. Nishant's talk. Okay.
Yeah, I can speak now. Can you share my slide?
Meantime, I'd just like to say, Dr. Priya, this was a fabulous talk and very, very concise and precise. Covered everything so well. Very, very good. Right from how trachea looks like, I think it was wonderful. So after this very informative talk, over to Dr. Nishant, please. Can we?
Yeah.
Dr. Nishant, are you playing your slides or Dr. Hardik?
Yeah, no, he's showing.
Okay,
so
great.
Full screen. Yeah. So this is a talk now. This is going to again very basic, and the common problems which we face in our work is what I'm going to talk now. So if you see, the ultrasound is compared with the X-ray and with the CT scan. So CT scan gets 5-star, ultrasound gets 4-star, and X-ray gets, I think, 2 stars less. We should give 3 stars, because I'm talking about post-procedure complications, which is the best test to diagnose. And in the middle of it, you're seeing a very good wireless ultrasound, which has got a nice curvilinear linear probe with your own phone. You can just Bluetooth attach, and you can just do it and diagnose. So I'll come straight to my talk. Next slide. So disclaimer slide, next slide. So the roadmap of how I look at the complications, so the complications can either happen if I'm doing an ultrasound guide procedure, and that is rare because I'm already using ultrasound machine. So I don't think I will see a complication, but generally I will see more complications because of other interventions. As a pulmonologist, I might be doing a lung biopsy, bronchoscopy lung biopsy, or maybe cryo biopsy, whatnot. There we can see something called pneumothorax. So somebody has a CD guide biopsy for a lung mass, you can see pneumothorax. Somebody's put central line and you can see pneumothorax. I can see hemothorax after a biopsy. Then again, somebody is in the ICU with a positive pressure ventilation, I can see pneumothorax. And sometimes even ultrasound can tell me that, look, do not do a procedure, it's still fine. So the rate of these complications are overall very low. And you should always discuss when you are consenting your patient for the procedure. Tell him that what is the risk of pneumothorax, what is the risk of bleeding, what is the risk of lung injury. All these are below 1 to 2%, but you should always talk. Next slide. So I have one cases for each of these scenarios. This is a very interesting case. This is a 60-year-old lady admitted in a surgical oncologist, post-op C ovary. She had ileus with low potassium, subacute intestinal obstruction. They were planning for re-exploration. She's obese lady. Because of no peripheral lines, they went and put a left subclavian vein cannulation in the OR by anesthetist. The chest X-ray is done very carefully, nicely, and it is normal. It is documented. Chest X-ray is normal. Overnight, she told she had some shoulder pain, and by morning she had some breathlessness. By the time I was consulted by 10 o'clock in the morning, they called me saying patient has thoracic chest pain. Shall you do CTPA? That was their query. I went and saw the patient, examined the patient, tachycardic, heart rate of 100 per minute. But when I examined the patient, I think when you are listening to the story, you also might be getting carried away that, okay, X-ray was normal after 2 hours. But please examine the patient, and that's where the clue was. The breath sounds were reduced on the left side actually. So I immediately asked for ultrasound machine at bedside. Next slide. And I do ultrasound straight with the simple curvilinear probe in the M mode. Play the video, please. And I immediately pick up the lung point. It's in the mid-axillary line. And I'm very sure it's pneumothorax, nothing else. But the team is telling me that, are you sure? They're saying, what is lung point? Shall you do CT scan? I said, nothing. Just do X-ray. Let's see that. So here, after ultrasound, I had an X-ray to document pneumothorax, and it was there. Next slide. And that's the pneumothorax. You can see the lung border. So this is a case of delayed pneumothorax picked up by ultrasound on the bedside, where your referral team is pushing for doing a CT scan, CTPA, whatnot, and nothing is required actually. You can get after subclavian vein cannulation. Delayed pneumothorax, I don't know, but it is possible. So the thing is, clinical examination and careful use of ultrasound machine can pick it up. So next slide. Immediately I put a chest tube, 16 phase French Seldinger, lung expanded very well. And next day pulled out tube. She is very fine now. She is doing well. After 2 days, she was taken for re-exploration. She is fine. So she could not go for next GA without getting this pneumothorax out. Next slide. So that's the importance of ultrasound at the bedside and clinical examination also. We should not get carried away by jumping to do CT scan or CTPA. So in my mind, if I look at it, how do I quantify pneumothorax? So this is a CT scan. You can see there are 3 probes, R1, R2, R3. If I see my lung point at R1, the pneumothorax is going to be small. If I see my lung point at R2, it's going to be moderate. If I see my lung point at R3, it's going to be large pneumothorax. So this is just to keep in your mind. Next slide. So when you are trying to see a patient bedside, always look at, remember these 3 lines, mid-clavicular line, mid-axillary line, and posterior axillary line. If you find lung point at R1 again, as I said, it's going to be small pneumothorax. You can still wait. But if you're finding lung point at R2, you cannot wait, put a tube or carefully watch the patient, put on 100% FiO2 with 15 liters so that some pneumothorax can resolve. but don't wait there. And if you had R3, then definitely chest tube has to go in. And if you're seeing lung point. So next slide. So just one slide here to show this study. Very interesting study actually. They compared CT scan size of pneumothorax with lung ultrasound prediction actually, and they divided a class of pneumothorax into three: 1, 2, and 3. 1 is below 10% on CT scan. 2 is up to 30%, and more than 3 is 2 is up to 30%. More than 3 is more than 30%. What they found is that if the pneumothorax is small on the CT scan, you will get lung point anterior to mid-axillary line. The pneumothorax is moderate on CT scan, you may get lung point on the mid-axillary line, and if the pneumothorax is large, you may get lung point posterior. But what was the caveat here is the prediction value of large pneumothorax started falling. The reason for that I'll tell next slide. So next. So next slide. Yeah. So what is the reason for low prediction of lung ultrasound to detect a large pneumothorax compared to CT scan? That is the next slide. Next slide. So this is the reason. Next slide. So if you see, once the pneumothorax volume starts increasing, the absence of lung sliding starts increasing in an arc from anterior to lateral portion of chest. And as the volume of air further increases from medium to large, you may find that lung is further being pushed from the chest wall, but the surface in which lung sliding is absent increases less significantly because of lung being pushed away more. And that's the reason why you cannot see, or you may not see, lung point in a very large pneumothorax, because there is no lung coming in contact, because the whole lung gets collapsed. So that's where you have to be very careful in a large pneumothorax. Up to moderate pneumothorax, you are very sure that you are 100% correct. Next slide. Second case now. So this is another very interesting case. 62-year-old lady transferred to my hospital ICU from other ICU in the city. Prolonged hospitalization. She was on a mechanical ventilator. Post-op abdominal surgery. She had later multiple infections. In the lungs, she had some endobronchial clots. They tried twice but couldn't get it out. And then she was referred to. This is X-ray. Look at it. Very nice, clear X-ray. But she has got severe pneumonia. There's ET tube. Next. So next. Yeah, video will play the video. So this was a clot there. I removed the clot with the cryo. It's a thick organized clot. The entire clot was sent to the microbiology, and it grew heavy growth of Aspergillus fumigatus. BAL was also positive, and you can see in the right side it's cleared. Bronchus intermedius very much clear. While doing cryo extraction, we used very high oxygen and PEEP of 12. Downtime was around 15 minutes. Next slide. We do X-ray after 1 hour, and you can see this. There's a deep sulcus sign, and there is the pneumothorax, very small. So when a patient is on ventilator with a deep sulcus sign, with even a small pneumothorax, we tend to put a tube. Here also we planned like that. We kept everything bedside. But when I just put the probe, I found lung point is very medial actually. It's in the mid clavicular line and even further that. So we thought pneumo is very small. Okay, let's wait for 2 hours. We just waited like that. We reduced the PEEP, and she was not unstable hemodynamically. So we just waited. Next slide. You can see the lung point is, the deep sulcus is cleared, pneumo is also cleared. We kept doing X-rays next day, second day, third day, fourth day, but she never had pneumothorax after that. So I think some of the pneumos resolve with oxygen. We need to take into account that there's no need to jump. Ultrasound helps here. Next. So ideally chest tube should have been put, but a thorough ultrasound examination helped us here, and we reduced the PEEP, and it was a joint decision. We waited, and it worked well. Next. So deep sulcus sign on a patient with positive pressure ventilation, in most scenarios, we need to put chest tube because we don't know when suddenly patient will decompensate. The reason for that is when the patient is supine, the deep sulcus is the only manifestation of pneumothorax, but that is to be olden days. Now we have lung ultrasound, we can see it. The reason for this is air gets collected basally and between the dependent portion of the lung and the chest wall. So the costophonic angle gets deepened with the deep sulcus sign. Next. So this is just, I took a picture from other series. So in the left side, you are seeing the scout, you are seeing deep sulcus, and exactly how the CT scan will show. And when you do the CT scan in that side, you will see the lung point there. So generally we should put the tube, but if you can monitor the patient very well, then you may not also, it may get resolved. So that was about deep sulcus. Next. And this again showing same thing, same patient when you made supine, you saw the lung point moved up. But when the same patient is lying down, the deep sulcus point is down. So next. The third case, again, 60-year-old male. This guy has lymphoma, progressive lymphoma. There's a left hilar mass almost going up to the chest wall, small effusion. Hematologists is trying their best, but they can't cure him because none of the medicine is working. So they plan to do a CT guide biopsy from that mass which is coming to chest wall. I was not consulted till that time. They did the biopsy. There's an X-ray also in the system. I just saw there's a effusion, very small effusion, but otherwise X-ray is okay. Next, after the biopsy, the patient was planned for discharge, but he was breathless. So they called me at 5 p.m. I go and see the patient. Stats of 85%. Tachypneic, tachycardic, BP was okay, and there's a left hemithorax whiteout. So seeing this, what you'll do, you'll just shift the patient to ICU and you'll start working on it. So next, in the ICU, maybe after 2 hours, I think I was busy, I came later 2 hours, we sent hemoglobin. There was a drop of more than 2 grams, but still not fulfilling the hemothorax criteria. But yeah, there was drop in hemoglobin. So I thought there was oozing, so I put the ultrasound probe. Next slide. Video, please. So you can see here, you're seeing the lung mass. Yeah, you're seeing the lung mass. After that, there's a effusion. This effusion is not anechoic. It looks very much echogenic effusion. You can see inside some debris there. Diaphragm is pushed. And with this sort of history, after the biopsy, patient has developed this whiteout lung. So you want to put chest tube in this. So I put a tube here. After putting chest tube, patient got better, but lung was not expanding. Next slide. Then next morning, I again did ultrasound, put the probe anteriorly like before. Next, play the video, please. Video. You can see even after draining 600 ml of fluid, the lung is not, upper lobe is still collapsed completely. So now you plan to do a bronchoscopy here because you want to see if there's mucus plug. Next, there's upper lobe complete collapse. Next. So after putting tube, after doing the ultrasound, did the bronchoscopy, you got the plug out. There was a thick mucus plug, removed with forceps, suction, whatever. And now you can see lung expanded. Next. So here actually the plan was to quickly discharge the patient because he was already in palliative mode. So we had to do it and chest tube was inside. So we got that. Patient was discharged after that with oxygen. Next. So ultrasound actually here helped. Generally when we see a whiteout lung, we just jump and ask for a CT scan or HR CT scan. But if you do CT scan here, you won't find anything else. You'll just see effusion and whiteout. So initial chest tube, then bronchoscopy. This was all helped by ultrasound. Next. This is another case, very interesting case, pneumothorax as a complication after pigtail insertion for a massive effusion. This 65-year-old male, 40 pack years, came to ER in the night with progressive breathlessness, 2 weeks, stats of 86% room air, tachypneic, background COPD, because he was very breathless. The on-call radiologist came and put a pigtail. And I was called in the morning. Next. So when I see the X-ray in the morning, this is the X-ray. If you see the X-ray carefully, you will say, okay, lung expanded, it's fine. But actually, there's a pneumo in the X-ray. To me, it looks like. I just put the probe to see effusion and whatnot, but I could find the lung point straight anteriorly. I could see. Play the video, please. So in this picture, you are seeing video, please. Yeah. So in the right side, lung is not sliding. Left side, lung is sliding. That's the lung point. And then I'll show you stratosphere sign. So this is with the pigtail in. We are trying to say that, yeah, there's a pneumothorax confirmed. It's a loculated pneumothorax. So you can see the stratosphere sign will come. So with this, what you will do now? You will have to pull out the pigtail and put a chest tube, or you will do a CT scan also. Here, I would do a CT scan because I want to see the lung. I have to check where is the pneumothorax localization because this is a complicated case now. So next, I did a scan. Maybe air has, these were my thoughts why air has gone in. Maybe it's iatrogenic, but definitely CT scan was required here to document definite pneumothorax. Next, yeah, so this is the lung point here. You can see it's anteriorly loculated and pigtail is still in a smaller pocket. You can see lung mass also. Next slide. So we found the lung point. Chest tube was put anterior to the lung point. Next slide. And there we go. We have the new chest tube. Lung expanded. We did the biopsy, CT guide biopsy, and also we could do the fluoridesis. And patient was discharged after that. Next. So here ultrasound actually helped us in planning the procedure, defining the problem, asking for the right test actually. CT scan was asked after that. So this is the last case actually. This is a bit uncommon case, but it may happen when you are doing patients The 60-year-old lady admitted to our ICU with severe LVF, bilateral effusions. Right side was large effusion. I was consulted by cardiologist because she was requiring continuous NIV. So I volunteered to do pleural tap. She had 1.5 liters fluid, was backmedially transudate. So I just did therapeutic tap, simple, and the 950 ml fluid was removed. She was fine. We could take off the NIV, put her on oxygen 3 liters, and she was comfortable. I went to my OPD, started seeing my patients. After 1 hour, I get a call from the ICU consultant. Severe breathless, orthopneic, intubated. Immediately I came back, did the ultrasound again. There was no pneumothorax, no hemothorax. Because first thing you'll think is, have I made a pneumothorax? Have I created a hemothorax? So X-ray came, everything done. She was intubated. We started furosemide infusion. She actually improved very quickly, and she was extubated next morning. So it was actually re-expansion pulmonary edema. I don't know why at 950 ml only she had this. Up to 1 liter or 1.5 we can take out, but maybe she was sick and I removed more. Next. So this is just a companion case from the literature I got, just to show, because that my case I didn't have the details. She was discharged a few months back. So this is a similar case here. You can see that this patient has got effusion. Tapping was done, and in the right side you can see whiteout lung on the ultrasound. In the left side, lung is normal. So that is called re-expansion pulmonary edema. It is not very common, but it's not very rare also. Next. So there are two very good studies I could pick up. I'll just speak on this quickly and come out. Next. Very interesting studies. So I'll just summarize now. So when you talk about pneumothorax, if you are doing ultrasound guided pleural tap, the risk of pneumothorax is between 0.3 to 1.5% for pleural tapping. This is how you can talk to your patient. There's some rare entity called pneumothorax X vacuum or trapped lung. You do not worry. Suppose there's a patient with effusion, you remove the fluid and you're seeing hyperlucent area. It could be trapped lung, so don't worry about that. There are some specific features of M mode. I'm not going to speak here, but also look at the X-ray findings. Some patients can have some sort of volume loss, rib crowding, diaphragm elevation. Those could point towards that this patient may have trapped lung. So that's called pneumothorax X vacuum. Next is re-expansion pulmonary edema. Incidence is around 0.2 to 14%, but these are patients are asymptomatic. But with significant symptoms, you will have less than 1% of patients. And the maximum time for onset is up to 24 hours. So don't worry. Don't think that within half an hour they didn't have. It's fine. My patient had after 1 hour. So ipsilateral is more common than bilateral. How to prevent? Should not aspirate more than 1 liter. Actually, if you read, they'll say 1.5 liter in UK and all, but I think 1 liter is enough. How to prevent it? You can do pleural fluid manometry. And what do you target? You target pleural pressure more than -20, but it's not feasible. We can't do it. So try to tap less. Pain after the intervention, like pleural tap, chest tube, whatever, it's common, 5 to 39%. So use adequate analgesics. Bleeding is very rare because of organ puncture like lung injury, liver injury, spleen injury. Always use chest ultrasound. Search for intercostal artery. It's rare to find, but if you find, you are lucky. Don't puncture it. And always avoid out of hours elective procedures. Like after 5 p.m., some patient has got chronic renal disease, chronic liver failure, and you just wrote in the file ultrasound pleural tap by radiologist. Patient went at 6 o'clock. He taps and sends the patient back to the ward. I don't think that's really a good practice. Because you should do it in the morning times. IPC infection rate is low. Overall, it's less only. When you are planning for a closed pleural biopsy, always use in-plane method where you can see the whole needle path. Lignocaine dose 3 mg per kg for skin and parietal pleura. So make it a point that you're not crossing this. Have a checklist in your work environment. There's something called universal protocol checklist, including bleeding parameters. Look into it. It's there. You can print it out. You should have timeout when you're doing the procedure, and you should have bleeding pathway in your work. You can have mock drill, and you should always check whether doing the procedure is going to gain any benefit for the patient. Will it change any management? Then you should do. Next. So this is just one video showing what is in-plane technology. So this is in-plane. You're seeing the whole needle. This is apical, upper apical loculated effusion. This is how you should do it here. You can see the whole needle in the fluid. Similarly, if you are doing a biopsy, the whole needle should be seen, and then only you should biopsy. So this is important to be sure that you are there. You're not overshooting and not causing puncture the internal organs. Next. I'm almost done. So next slide. So be faithful in small things you do, because your strength lies in small things. That's all. Thank you.
Thank you so much, Dr. Nishant. I think this was extremely informative. I think so nicely you've told us how to do things so as to not get complications, how to identify complications, when to intervene, and how perfectly to intervene. I think this was fabulous. I think we've had 2 hours of non-stop, brilliant, mind-blowing teaching. I mean, next time when I'm going to look at the USG screen, my eyes are going to see so much more than they were seeing before 8:30 p.m. today. We have had, I think, some 24 questions, and more questions are still coming. But our faculty have been kind enough that we will respond to the questions and we'll email the answers like we've been doing in almost all our webinars. And I'm happy to tell everybody that we have 1,744 logins, and each of the 1,744 logins are still present. So a huge big thank you to our fantastic faculty for truly taking a masterclass in the actual word of it. I have learned so much. A huge big thank you to the huge number of delegates who have actually logged in and have remained logged in for more than 2 hours. They've asked us so many important questions, which makes us feel that you all have been so involved and so interested. A huge big thank you to our ICS for making sure that our academic march continues. And thank you so very much to Team GSK, our academic partners, especially Dr. Hardik and Dr. Yogesh, who have made sure that we keep on giving fantastic academic information one after the other. A huge big thank you, dear Priya, dear Uma, and Nishant. Would you like to say just something about USG, one message to the audience from each of you, starting with Dr. Priya?
I would say it is a very good tool, but use it judiciously and diligently learn the process.
Wonderful. A teacher has spoken. Yes, Uma.
Yeah, I would definitely second that. Yeah, always we have to keep in mind our basic clinical skills, history, examination, and always interpret the ultrasound, because what I said in the talk also, and every day, it's all interpretation of artifacts. So we need to know how to fit in the jigsaw puzzles and come at a conclusion. So it is not one day we'll see and the next day we'll be able to interpret. We need to have that rigor and go through it, and then definitely, yes, it's a most valuable tool. It can replace the stethoscope, as you said.
Wonderful, wonderful. But clinical examination is equally important, as Dr. Uma rightly said. So well spoken. Thank you. Dr. Nishant.
Yeah,
Before you speak, just a minute, I just want to remind the delegates, we've got huge numbers of initial question answers in the poll. Just please go to chat again and please give us the feedback so that we know how much you all have learned after our webinar. Dear delegates, please do that. Over to you, Dr. Nishant.
Yes, so I would just second to what Dr. Priya and Dr. Uma said. I think clinical examination is very important. Otherwise, you may get carried away to do more things. And also, it's very important to decide your procedure time and all out of hours with deranged parameters. Be careful and then plan accordingly your procedures, and always go by your clinical extent, not just ultrasound.
Wonderfully said by all our 3 teachers that this is USG you have to know in today's day and age, but nothing can replace our clinical skills. So USG will always add on to our clinical skills, and probably USG may just replace our stethoscope or chest x-ray, but currently everything is a invaluable package, and we all have to learn ultrasound, and we are grateful to our 3 masters of today who have wonderfully guided us through this beautiful enigma of ultrasound in thorax. Thank you so much.
Ma'am, can we ask the participants just to fill the post poll and feedback once?
Okay, I already did, but a request once again to the participants. Can you all please fill the questions in the poll and also the feedback forms, please? We'll be really grateful. I think with this, I'd like to end our webinar, which has gone on almost for 2 hours, 15 minutes, and we still have 1744 logins all through. This has been really a record, and thank you so much. Our 3 teachers deserve all the credit for it. So grateful to all 3 of you all for giving us time, sharing your knowledge and being on board.
Thank you.
Thank you.
Thank you very much.
Thank you.
Thank you, everybody. Thank you. Good night.
Good night.
Thank you. Good night.
Good night.